Before any clinical examination, the clinician must wash their hands before approaching the patient. Introduce yourself to the patient and explain the procedure fully. Next, you must position the patient in the correct way. In the case of the abdominal examination, the patient needs to be supine with their arms by their side. Check the patient is comfortable before fully exposing the area that you wish to examine, maintaining dignity for the patient at all times. Inspection begins by generally observing how the patient lies. Asking them to take a deep breath in and out may reveal any rigidity or tenderness in the abdomen. Asking them to cough may reveal any large hernias. Moving on to the specifics, look in the hands for a loss of the angle of the nail bed or a boggy feeling. This is indicative of clubbing. Next, examine the palms of the patient, looking for signs of Dupuytren's contracture or palmar erythema. A gross assessment of the pulse at this point may be advisable. Moving up to the face, look in the patient's eyes for any signs of jaundice. Asking them to stick out their tongue and open their mouth wide may reveal ulceration of the oral cavity or glossitis of the tongue. At this point, a full examination of all lymph nodes in the neck, both anterior and posterior triangles, must be carried out. Next, fully expose the chest and examine for any signs of spider nevi, also looking in the abdomen for scarring, distension or any other signs of pathology. Finally, ask the patient to put their hands out as if stopping a bus. This will reveal any liver flap. Palpation is best done at the patient's level. Begin by lightly palpating systematically through all 9 areas of the abdomen. Ensure throughout the examination that you look at the patient's face to pick up any signs of tenderness or pain. Then, move on to deeper palpation, again systematically working your way through all 9 areas of the abdomen, feeling for any masses. Next, ask the patient to take deep breaths in and out. On inspiration, the hand moves in and upwards, feeling for a mobile liver edge. The same is then done, moving across to the area of the spleen. If enlarged, the kidneys may be felt by ballotting them, using the dominant hand underneath the patient and trying to bounce the kidney against the anterior hand. Finally, the clinician can check for any abdominal aortic aneurysms, which may be felt as a pulsatile mass in the midline. Percussion can also be used to grossly assess for the size of the liver, identifying the inferior border and the superior border to reveal any hepatomegaly. The same can then be done moving over to the area of the spleen to look for splenomegaly. If the clinician suspects ascites, the shifting dullness test can be performed. Starting in the midline, the clinician percusses out to the right flank until the note changes to a dull tone. Asking the patient to roll onto their side will let any fluid drain away, and the note should become resonant again. Finally, auscultation of the abdomen is important. Firstly, to assess for normal bowel sounds. This must be done until the clinician is happy that they have heard normal bowel sounds. Next, listening for any bruits over the left renal area and right renal area, over the abdominal aortic area, and over the femoral vessels to reveal any signs of vascular pathology. This concludes the abdominal examination. Reposition the patient comfortably, back at 45 degrees. Thank them and wash your hands thoroughly.